So, as you see, I choose the title, How to Have a Yasargil's Control when he is not present. Is there any other control? I was fortunate to be able to operate in Yasargil's operating theater in 1990s. And once I was operating an aneurysm, he came to the OR and then he said, compress, compress. The brain is not yours. This was like a hit, like a knife into my brain. I will never forget it. And then I started to understand that we can use the spatulas to hold the brain, yes, but not to compress it. The aneurysm clipping, everybody can do it. I hope you agree with me, but the cost is very, very different. At that time, decades ago, Maurice Albin, he did the experimental studies on monkeys by pressing the brain with the spatulas and then studying how the biological events go on after too much compression. And this was a clear proof that we should not compress the brain. Approach to the target, respect the brain's anatomy, and do not destroy it. Get in, fix the aneurysm, get out without leaving traces of being there. That's the main aim and mantra. The guidance, you all remember that Babinski helped Thierry Demartel to show him what to cut and what not to cut. Clovis Vincent profited from both, and so the neurosurgery in France was born. It was before the World War II. In 1968, Yasargil taught neurosurgeons how to use microtechniques. In 1970, at Vienna meeting, the first microsurgical meeting, he showed us how to use magnification. But since 1980, we need self-guidance, which should be equal to Yasargil's control. He's not staying behind us. And how is this possible? We have to position the patient by ourselves. We have to select the correct protective dura opening, gentle arachnoidal dissection, and absolute pia and vein preservation. If we do this, then it is like Yasargil was behind us. Now, I'm sorry, I have to go now to the sorry, I would like to show you how to do this.
Little Rock.
Little Rock.
Movie. Yes.
So, our surgery has to be bloodless. We have to use the structures, and we use arachnoidea, which we put on stitches, and we hold it left and right, so we come into the Sivian fissure. There are many strands between the temporal and frontal lobe. And Yasargil always said, I don't know why people don't like to study this. And some of them are weak, some of them are strong, and you have to cut them.
Vinko,
Vinko, is this sorry, Vinko, is it a video?
Pardon?
Is this a video or is it a standing picture? Video is not playing.
Video is not playing. Sorry.
Yeah.
Just video. Can you see that?
Can you see it now?
No, it's not on so. Slide so. Go to slide so, Vinko. Slide so. It's not in slide so.
That's video.
It's not playing on the screen.
Should be.
Exit screen and then
Sorry.
go back and again.
Yeah.
It's better
Now.
Oh,
Yes.
sorry.
Yeah.
You
You can continue now, Professor
Go
Vinko.
ahead. Go ahead. So we use arachnoidea to help us to hold the brain. And by using this, we can proceed into the Sivian fissure, actually without any trauma. Some of threads we can tear, the others we have to cut. You can bring a person from the street and you will be able to teach him in a rather short time how to put a clip on the aneurysm, but you will not be able to teach him how to access, how to come to the aneurysm automatically. And I think this is the most important lecture we got from Yasargil, how to make our way atraumatic. And we use for this as a self-control also the longitudinal incision of the dura along the Sivian fissure, in order when we put the spatula to each side, then the dura is preventing to compress the brain too much, because you are focused on the target. You are not focused along the tunnel. But if you don't put the spatula, it is even better. And you see, you can dissect and visualize the structures and preserve the veins. And the most important and critical point I would like to show is to preserve all the veins. When I showed the first time this video, Professor Yasargil asked me, which is this vein? Not this one, but in a moment you will see it. The pia is not damaged, so we don't need to hold the brain anymore. We go further. Now we come to the vein which is crossing from the frontal lobe over Sivian fissure to a major vein. Don't cut this vein, because this is not gentle enough dissection. So preserve the vein, and when you preserve it, you can be sure that your dissection is gentle enough. The last decades, even many decades, neurosurgeons were always considering arteries. We never, ever paid enough attention to the veins. But the veins are very, very important, because they don't punish you immediately. they will punish you tomorrow, day after surgery. So preserve the veins, even the tiny ones. When you take time for the approach, it is not wasting of the time. This is just doing the right thing. Now we are processing further down to the anterior communicating artery region. And the retraction of the brain by suction tube is short lasting. And then you do not disturb the perfusion of the brain. You retract, you release, you retract, you release. So we don't need permanent spatula compression. And we came to the aneurysm at the anterior communicating complex. The optic nerves, the other ACA1 on the other side. So we have to explore carefully, atraumatically, the neck of the aneurysm, the origin of the aneurysm, and all the arteries, the parent and daughter arteries. Adherent is the aneurysm to the surface of the optic nerve. You have to cut this to dissect and to mobilize the aneurysm completely. Only then you are able to put the clip as it should be. So, and it should be this way that the aneurysm is excluded and the artery is not stenosed, is not narrowed. The ACA1 on this side and on the other side. Don't just put the clip and go away. You have to check. You have to see if the positioning of the clip is correct. You may reposition it when you have a safe and sufficient exposure. And then, of course, additionally, you also coagulate and so on. This actually was an aneurysm which was located at the double ACOM artery. This is ACOM, this. And the whole situation must be clean, clear, bloodless. Okay, we can go further. No. Okay. Yes, for the next one. Yeah. Now exposure. As I said, it should be sufficient space proximally and distally to the aneurysm. No need to expose the entire aneurysm dome. And don't extirpate the aneurysm sac by force. It is dangerous. Carotid ophthalmic. It is very nice if you study first the anatomy and you get familiar with the interdural space and extradural space. And then you can deal with such an aneurysm, which is and now okay. Sorry. Yeah.
Here.
Marți. Mare.
Verona.
Aia.
Yeah. Yeah. Again, yeah, that's correct. That's correct. That's correct.
Yeah.
Sorry. Here, with this case, I would like to present the approach to the target. Sorry. Yeah. Yes.
Oprašiće video.
Is it okay?
Yes.
So we are in the area of the Sivian fissure, very down. Again, we have to preserve the veins. We have to visualize the artery, and we have to visualize the aneurysm. The aneurysm is here. The artery is here. So we are at the distal side of the neck. We don't see the whole aneurysm, which we know is big, but we don't need. This is the brain over the aneurysm. So what we need the space here that is around the neck. And we have a distal carotid, which is here, carotid aneurysm. But to visualize the neck of the aneurysm, we have to join the extradural space, which is available after removal of the anterior clinoid process. We cut the dura. We come down to the dural distal ring, and we explore the neck of the aneurysm much better. The optic nerve here is covered with the dura. We don't see it here. It is running around the aneurysm. The brain is still covering the aneurysm, but we don't need to see the whole aneurysm. We need to see the neck, and when there is not enough space, we drill the optic strode further. And then we come to the distal, that's actually proximal part of the neck of the aneurysm. We have a distal side of the neck, and we have a proximal there. So what we need to is just to hold the aneurysm, because we know the arteries here and here, and this is the optic nerve now getting free. Then we put a clip and we open the aneurysm, we empty it, and we leave the sac of the aneurysm. So the optic nerve is free now. We cut the aneurysm, and then we empty the aneurysm, and that's it. So don't pull the aneurysm sac out at this region. It is extremely dangerous and may have a bad effect.
Another one.
Let's go. So this is the result before surgery and after surgery. Carotid ophthalmic artery is preserved. is another case, pretty large, and you need space in front and proximally, and then you can deal with this aneurysm. Like this. This I operated when I was with Professor Yasargil in Zurich, and because it was not possible to exclude it via endovascular treatment. So, in summary, we approach in epidural space down to the target. We cut the dura along the CVM fissure in order to have a protection if we need to put the spatula. We visualize the optic nerve, and this is the space after removal of the anterior clinoid. So we have a proximal carotid in the extradural space, the dural ring, the neck of the aneurysm, and the distal ICA. Here is the clip on the aneurysm, curved, fenestrated. Here's another case, similar. We need the space extradurally, and I don't know why we should not remove the anterior clinoid. Now, cavernous sinus aneurysms, absolute indications, bilateral fusiform traumatic, and provide the safe dealing with the aneurysm is by resection of the anterior clinoid, then dissection of the ICA and optic nerve free, distally and proximally control of the blood flow through the ICA, through the cavernous sinus. This is distally, optic nerve, anterior loop, cavernous sinus, and this is posterior to the cavernous sinus, the posterior ICA loop behind the Gasserian ganglion. Then you can put a clip here, put a clip down there, and then you can work and you can resect the aneurysm in such a case and reconstruct the ICA from here to here, ophthalmic artery. Bilateral, you operate first on the side where is bigger aneurysm. Then the smaller one on the other side may not grow for very long time. You follow this. The other question is when you have an intradural and extradural aneurysm. And you have to, because it bled and was subsequent hemorrhage, so we had to do something. And that is the post-operative result after resection of the aneurysm and reconstruction of the carotid. Another similar case before and after. He was reconstructed artery wall here. Large and giant intradural aneurysms, like this, 5.5 centimeters in one diameter and in the other 5, and not having the ACA1, you have to remove this aneurysm safely and to preserve the patency of the ICA as this one. And this is all possible when we have an extradural space connected at surgery with intradural space. Then we have an anterior communicating aneurysm, which is thrombosed. And this is a much more difficult case, and you need a lot of space. And where to get the space, it is anteriorly at the account of anterior clinoid and the skull base. It is shown that there is no ACA1 on the left side, and the complex of the ACOM is not normal. And this is after resection of the aneurysm, emptying the clot, and reconstruction of the ACOM complex, and you see that both ACOM2 are present after surgery, because this patient did not have a ACA1 on the left side. Indication for surgery of the basilar deep aneurysms. They say it's not indication anymore, but I don't agree. I don't agree. And this is indication when we have a large, complex, or failed multiple coilings or stenting. We have to operate. As this case, after coiling, there was bleeding. The next coiling, again the bleeding. This is after surgery. Coils in the aneurysm. Communicate perforators behind the aneurysm. So you remove, you resect the aneurysm, you put a clip, you preserve the perforators. But prior to operate on basilar deep aneurysms, one should be familiar with aneurysm surgery along the corridor. This is a must. I cannot stress enough how important it is. It is like to climb the, I don't know, the highest mountain. But you have to be experienced enough to widen safely the corridor, open the sylvian fissure, and shift the cavernous sinus wall laterally. Why? Because it's not the same if you shift the carotid from the medial to the lateral side. You stretch the perforators, and it might be too much. It's much better and safer if you remove the anterior clinoid, posterior clinoid, and then you work through this space, and you get better view, better approach, and you do not harm the perforators. That's as illustration. Remove the anterior clinoid process, posterior clinoid process, and come into the posterior fossa between the horizontal portion of the carotid in the cavernous sinus and intradural carotid behind the anterior loop of the carotid. And then you can exclude such a complex aneurysm and preserve the perforators. This is the most important. These perforators are unforgivable. If you put a clip once on the perforators, they will not function again. In conclusion, respect different locations of the aneurysms: extradural carotid, intradural carotid, vertebrobasilar. Mind the size and content of the aneurysm. The aneurysm might be with a clot, and mind the quality of the neck and condition of the arteries. Then we have a ruptured, unruptured aneurysms, different issue. A traumatic approach is mandatory and sufficient exposure of the parent and daughter arteries and the neck of the aneurysm in all cases. When clipping is not possible, resection of the aneurysm, reconstruction of the artery wall with suturing, wrapping, and reinforcing with cuff clip might be needed. Sometimes no clipping, no resection reconstruction is possible. Then the bypass surgery comes into question, either short high flow or EC-IC bypass. So vascular neurosurgeon has to be familiar or have to have a friend who is able to perform bypass surgery. That's why large neurovascular centers are needed with first-class diagnostic procedures available, good endovascular treatment possible, experienced neurosurgical and anesthesiology teams present, and individual consent from all the colleagues for the kind of treatment of each patient. In the conclusion 3, I would say that small and large and giant aneurysms are all aneurysms, and they do call for serious consideration for the treatment. Operating an aneurysm is not equal to treating a patient with the aneurysm. Keep in mind that we treat patients with the aneurysms and not the other way around. Thank you very much.
Thank you very much, Vinko, for this wonderful presentation. No doubt your presentation is another testimony that microsurgical management of aneurysm is here to stay, flourish, and be taught to younger generation. Well, thank you very much. I think I'll just